Breast reconstruction can be an overwhelming process. This video is designed to give you a brief overview of the process and options of breast reconstruction before visiting with your plastic surgeon. We hope you find this video helpful. We know that this is a trying time. Research has shown that breast reconstruction can help improve your body image, self-esteem, mental health, and quality of life after breast cancer surgery. There are three main options when deciding what to do after your mastectomy. You can do nothing and focus on getting over this major hurdle. 2, you could choose an implant-based reconstruction. 3, you can choose autologous reconstruction. We do want you to keep in mind that the two options displayed are additional surgeries after your cancer treatment or mastectomy. First option displayed on the last slide, implant-based reconstruction, can be performed in a 1 or 2-step process. The 1-step reconstruction is when an implant is inserted at the time of the mastectomy, as known as direct to implant. The 2-step reconstruction is when a tissue expander is inserted at the time of mastectomy. You are expanded over a couple of weeks, and then later an implant is exchanged for the expander. Of these two options, the 2-step procedure is more commonly performed to give the tissue time to heal. Step 1 of the 2-step reconstruction process. During your mastectomy, a majority of the breast tissue is surgically removed as part of the surgical treatment of breast pathology. Because a significant amount of breast tissue is typically removed, a tissue expander is often needed before an implant can be placed. An expander is a balloon-like device that is surgically inserted under the skin and gradually filled with saline over several weeks. This safely and gradually stretches out the skin to make room for an implant. Additionally, an acellular dermal matrix, or ADM, is FDA-approved processed cadaver skin. It is often placed around the expander to help with tissue support, shaping of the breast. One advantage of having a tissue expander is that you get to see the changes to your shape over time and can decide when you are happy with the shape that will then be exchanged with an implant. Additionally, if you will need post-operative radiation, final exchange for the implant from the tissue expander will be done at least 6 months to a year after the completion of radiation treatment. The expander and subsequently the implant can either be placed in front of or behind the pectoralis major muscle, which is the chest muscle behind the breast. Your surgeon will help you to determine which option you are the best candidate for. After several weeks of expansion and when you and your surgeon are happy with your breast size and shape, surgery will be planned for tissue expander to implant exchange. During this second surgery, your surgeon will use the original incision scar to remove the breast expander and place an implant of similar size and shape. Implants are encased by a silicone gel but are filled with either silicone gel or saline, a saltwater solution. Silicone is more commonly used, but options can be discussed with your surgeon. Some drawbacks of implant-based reconstruction include risk of infection. They can look and feel less natural than autologous reconstruction. It is recommended to replace your implants on average every 10 years and an MRI every 1 to 3 years to check the position and implant integrity. Also, possible need for future revisions due to contracture, scars, asymmetry, or possible lymphoma, and overall reconstruction may take longer due to the use of tissue expanders. Our second main option includes autologous reconstruction. The word autologous means derived from the same individual and involving one individual as both donor and recipient. In autologous breast reconstruction, a section or flap of skin, fat vessels, and sometimes muscle is taken from another part of the body, such as the lower abdomen, back, or etc., and used to form a new breast. There are several options when discussing autologous reconstruction, such as the deep flap, TRAM flap, and Latissimus dorsi flap, along with others. We'll go into more detail now. One type of autologous reconstruction includes the deep inferior epigastric perforator flap, or the deep flap. For this surgery, there must be enough skin and fat in the lower abdomen for reconstruction to be considered. During the surgery, skin, fat, and blood vessels are taken from the lower abdomen and used to reconstruct a new breast. The second option under autologous reconstruction is the transverse rectus abdominis muscle flap, or TRAM flap. The rectus abdominis muscle is a long muscle that is a part of the abdominal cavity. It is also known as one of your ab muscles. The rectus abdominis muscle, along with skin, fat, and blood vessels, is detached from the surrounding area and moved from the lower abdomen to the chest to reconstruct a new breast. A third option under autologous reconstruction is the latissimus dorsi flap. The latissimus dorsi is a large muscle in your back, beneath the shoulder blades and behind the armpit. A portion of the muscle, along with the skin and fat that cover it, is detached from the surrounding area and moved into position to construct a new breast. This is a great option if you do not have enough belly or skin fat or have a history of radiation. While the deep latissimus dorsi and TRAM flaps are the most commonly performed autologous reconstructive surgeries at our institution, other types of autologous breast reconstruction exist. Other options can be discussed at the time of your visit and will be tailored to your specific case. Some drawbacks to autologous reconstruction include more extensive surgery, meaning longer recovery, having additional scars, and the potential for muscle weakness if a muscle flap is used. These are both great options for breast reconstructive surgery, but with any surgery, there are important risks to consider, including possible infection, changes to breast and nipple sensation, along with subjecting your body to more surgery. Here, we have created a side-by-side of implant-based versus autologous reconstruction. As far as implant-based, it could be less intensive surgery, which means a shorter hospital stay and recovery. It can look and feel less natural than the autologous reconstruction. There could be a possible need for future revisions due to contracture, scars, asymmetry, possible lymphoma, and the overall reconstruction can take longer due to use of tissue expansion. With the autologous reconstruction, it is more intensive, meaning a longer hospital stay and recovery, but the tissue comes from yourself and can feel and look more natural. You can have potential muscle weakness if a muscle flap is used, and there are commonly more incisions, which means more scars. Oftentimes, there can be dimples or sunken out areas in the breast after mastectomy. Fat grafting is a useful option for filling in these sunken areas to give breasts a more natural contour. It is most commonly used in the conjunction with breast reconstruction. This procedure is done at the same time as your breast reconstruction surgery. Fat is removed from parts of your body, such as your abdomen and outer thighs, by liposuction. This fat is then processed and injected into the breast areas that need it most. Your journey has not been an easy one. However, your journey in breast reconstruction can and will be individualized for you based on your preference along with your plastic surgeon's assessment of your body and reconstructive needs. We will do our very best to make this part of your journey as smooth as possible. Here is a flowchart of your breast reconstruction options. Please feel free to ask any further questions that you may have of any of the procedures.